Well, hello, it's Joel Dunning here at CTSNet, and it's my absolute honor and privilege to be joined by Professor Kenneth Liao from Baylor College. He has performed an incredible world first that we're going to hear about. We talked very recently to his chief, Todd Rosengard, about this incredible achievement. But as Todd said, it was all down to you, Professor Liao. This is phenomenal. This is a robotic heart transplant through a subxiphoid approach. This is completely a world first. And so firstly, congratulations for doing it. And just tell us a little bit about how this came about, the training that was required, and then of course about the big day and how you did it.
I'm Dr. Kenneth Liao. I'm a cardiac surgeon and practice in Baylor College of Medicine at the St. Luke's Medical Center, Texas Heart Institute. And my role is the chief of division of cardiothoracic transplant and the mechanical circulatory support. I also run the Center of Robotic Cardiothoracic Surgery of Excellence at the Baylor College of Medicine. So we do a lot of robotic heart surgeries at St. Luke's Hospital. And on a daily basis, we do 2 to 3 robotic heart surgeries. And we have a great team, and it's a routine doing robotic surgery in the past 6 years at the Baylor. And then also we do a lot of heart transplantation. Myself, we have been seeing this coming because we have operated upon the mitral valve surgery. That's through the left atrium, tricuspid valve surgery. That's through the right atrium. We operate upon the aortic valve surgery. So the aorta work on some congenital, so the cardiac disease that's very close to the pulmonary artery. And so it's all there. So we've been working on these components of the heart transplantation that are involving the atrial anastomosis, IVC, HVC, pulmonary artery, aortic anastomosis, all there. And we see this coming. We in our team we have talked about that. Okay, we're going to do the robotic heart transplant. Actually, we're trying to set up the cadavers in the lab in the anatomic department at Baylor, get used to it, and then we will aim at the subxiphoid approach. So while we're doing in preparation for this, and then we heard the group from the Saudi that did their pediatric transthoracic and thoracotomy approach and did heart transplant. That was encouraging to me, and then someone else is working on that. So that also gave us a sense that, hey, this is coming. I'm not the only one looking at doing the robotic heart transplant. Someone else in the other part of the world already just started. So while we're setting it up, so we actually did a few runs of doing heart transplants through a very minimally spread thoracic and sternotomy approach. We use laparoscopic instruments, just make sure this can be done that way. So we open the sternotomy, but we're not spreading much. We only spread about 2 inches so that we can perform everything through the laparoscopic instruments. That is basically the robotic type of instruments. So knowing that whether that can get to the depths of left atrium anastomosis and pulmonary artery anastomosis, aortic anastomosis. Actually, with these 3 cases with minimal spreading of sternotomy, we know it's doable. So, of course, we have a strategy. Certainly, we want to do all the anastomosis in a very efficient way. We try different tools to help keep the donor heart, left atrium, pulmonary artery, aorta in a certain fixed shape, so that would allow us to do the anastomosis. So we've been preparing for this. One day we have a donor that is local donor, and the recipient is the size anatomically is perfect. It's a tall, relatively thin gentleman, and who has been waiting for heart transplant for over 3 months in the hospital. He's stuck on the biventricular assist device and LVAD impeller 5.5 through the right subclavian artery insertion and protected dual from the right internal jugular vein for the right ventricular assist device. He also had ECMO device because he has some pulmonary edema, and then he had multiple issues. He had a stroke history. He had a few episodes of uh, questionable stroke event, but it turned out he had jaw dislocation. Anyway, he was very debilitated, waiting for the heart transplant. Now we have a perfect donor nearby, and that matches his size, and then we did it. It worked beautifully, and the total cold ischemic time was 3 hours 55 minutes. And we could make it even shorter, but then because donor side, we couldn't, even though it's a local donor, but we couldn't control the whole team perfectly because the other organs want to move ahead, So we finally were good enough. And as long as we can control it within 4 hours, typical cold ischemic time, and we're happy. So patient did well, very well and uneventful and no complications. The speedy recovery with regard to rehab, and he was able to get out of bed, starting to walk on the walker. Has not been walking in the ICU with BioVet for a long time, so he needs and that additional quick physical return to get better from surgery rehab. So this non-sternotomy and certainly helping a lot.
Yeah, absolutely amazing. And just could you give me a flavor exactly how you do it? So you're
Yeah.
describing a subxiphoid approach. Do you
So
make horizontal incision subxiphoid, and then where do the additional ports go? Give us
So yeah, so
how it's
interesting.
set
So
up.
here's what we do. So we made a subcypher incision like the old the Albert exchange. So we cut out cyphoid process, extended laparotomy to the about 10 centimeters, like to allow the heart can be put it in. We put the two trocars, typical mitral valve repair trocar at the fourth and the sixth intercostal space. Initially, I wanted to put the camera port through the xiphoid process, but then the angle was not perfect, so we used the subxiphoid incision. Once we cut out xiphoid process, we widened it towards the right side so that we can put the scope through the fifth intercostal space. Just because the L shape, so we can put a scope in a much better position. And then through this, the instruments and Chitwood cross clamp was placed through the second intercostal space, the cross clamp. We cannulated, let's say, we started with peripheral cannulation using the femoral arterial cannulation, that is a 17, or I forgot, 19 French arterial cannula. And we place venous cannula from the femoral vein and percutaneously using a 25 French venous cannula. And we exchange out his protected duo from the right IJ into using a 24 French venous cannula from the right IJ. And then we put him on cut lung machine. And then we take out the impeller 5.5 and repair the vessel. And then we started the pericardial opening using the robot and opening completely, open up. And then we use multiple tacking sutures like we do the mitral valve to hold pericardium on the right side towards the right chest. And then we deflate the right lung. We put the pericardium, open up through the left chest wall using the the crochet cutter Thompson needle to hook up the pericardial sutures to take the left side pericardium up as well so that we can see everything. And then we inserted a Chitwood aortic cross clamp and through the second intercostal space. And once we confirmed the donor is good, then we proceeded with cross clamping. And once we cross-clamp the aorta, we snare the HVC cannula from the right by passing umbilical tape around the SVC right atrium junction. We then transect the aorta and then transect did biatrial anastomosis. So By doing that, we were thinking this is the first case we used biatrial anastomosis. That would save us a little bit time. Instead of doing uh, 5 anastomosis, we only need to do 4 anastomosis. But I can see there's no issue to do biatrial anastomosis. But in this case, we decided to go ahead with the uh, biatrial anastomosis because we're not too sure about the size discrepancy between the recipient and donor, even though we pre-op, we have some idea about measurements that matches, but to give us biatrial anastomosis allow us to have a little bit more room, without tailoring the too much tailoring on the IVC, SVC part. It was basically save time. So we did, as a routine, we did the left atrial anastomosis first to be cautious. I used bovine pericardium to buttress the left atrial anastomosis circumferentially. And once left atrial anastomosis is done, we went through the pulmonary artery anastomosis. Again, we used bovine pericardial strips to buttress mostly posterior anastomosis, just make sure it's not bleeding, and anteriorly a little bit. And then we also use bovine pericardial to buttress the aortic anastomosis. And then we did the right atrial anastomosis without the pericardial buttress. So we actually, at the end of the anastomosis, everything done, we didn't even add any single and a suture for any bleeding or anything, just perfect. So we release cross-cam, we put a small dairy needle in the aortic root and let it vent. And the heart started beating shortly after we put it in, and we release cross-cam. And the measurement looks perfect. Everything just is good. We had a little bit post-op on the X-ray, a little bit right lung perfusion kind of injury issue, but this patient has previous pulmonary edema due to heart failure, and that has the CT findings that has lung consolidation on both left and right side. After surgery, then right side X-ray looks a little bit beaten up, but actually blood gas didn't change at all. So after the 3 or 4 days on the event, and the X-ray completely resolved, and back to normal. So it's a very good recovery, no complications. After surgery, minimal transfusion, chest tube output is very low, which is expected because we didn't open the sternum, so the blood loss is truly minimal, the drainage, and yeah.
Yeah, well, absolutely amazing, fantastic work. And it sounds like you absolutely nailed every single step, and probably, you do it exactly the same again, which is great. And I'm sure you've got plenty more plans. So, I mean, the next question is, I bet there are a lot of people out there watching that are transplant units and they've got a robot. What do you think the steps should be for people thinking about doing this approach?
So of course, and this is doable. There's so many increasing number of medical centers doing the robotic surgery. In our center, actually, particularly very efficient. So we do a lot of mitral valve surgery, coronary artery bypass as well. If we look at compare our like robotic mitral valve repair versus surgery versus open repair with the other team or the other group that in our center, we always much quicker than the open team. I have to say, people always say initial criticism, aortic valve surgery takes longer time. I think that's probably something that's the old history. Now, actually, it's faster. What happens is you go to femoral cannulation. That can be done very quickly, either percutaneously or do a cut down, and then you have the vacuum assistance, and then you do a mini thoracotomy and put the trocar in, go on bypass and open it up. Just start doing it once, and then you put the repair sutures in, and you see everything tested. And once it's done, you don't even close sternum, you just get, yeah, it's faster. So that would say that's why everybody is worried about is that time and issue. Just imagine that, oh, this is our first robotic heart transplant, and ischemic time is 3 hours 55 minutes. So I can see next time will be shorter. And of course, next time we're going to try to do by cable anastomosis. Yeah. But the first time to be on the sure side. And then, of course, also the first time we cut out xiphoid process. And then that's the main reason is for us, just in case, because first surgery, we prepared in case there's any issues, we have to convert to open. It's going to be quick convert to sternotomy. So I don't see much downside here by this approach. And simply, you're prepared if the robotic surgery doesn't go as smoothly, or you have certain area you want to see if there's any bleeding, especially I'm thinking about that the potential area of bleeding is behind the left atrial anastomosis. That requires the exposure to get it. But then, having said that, even with our other experience, and then we do mitral valve, do the tricuspid valve, do the left atrial appendage ligation. If there's atrial anastomosis bleeding, you can put a scope on the other side, on the left side, just add a stitch. Is not a big deal. So the things are changes, it's different. The experience and the repetition of the other robotic procedures and make this is possible. I can see in the future there's something's coming. I think without the subxiphoid approach here, I think is a good one because a lot of times it's a big bulky heart that needs to remove from the chest cavity. If you do a thoracotomy, you have to make a sizable size, but this through laparotomy pre-peritoneal approach, which we have done in the past by inserting the LVAD as a part like HeartMate 2, and that's been done through pre-peritoneal space. So we're familiar with that space. Actually, I first presented the first series of minimally invasive non-sternotomy and LVAD exchange in 2006 in the IHSOT meeting. That was for the old HeartMate XVE. And then after pump failure, we need to go back to change it out and then put a new pump in. So at that time, did subxiphoid approach, and then that can be done. So I know that the access subxiphoid approach pre-peritoneal space, you can easily access to the heart, and in combination with the robotic tools that inserted through in the costal space, this is totally doable.
Well, absolutely amazing. It sounds like the Baylor College of Medicine is just one of the world's leading institutes here. I'm sure Michael DeBakey's eyes would pop out if he could see the
Yeah.
incredible things you've done in his unit. It's truly incredible. So,
Yeah, I have to say this is an amazing place, and every day I walk into my office, I see Dr. DeBakey's portrait, and then Dr. Cooley on the other side, and Dr. Bart Fraser, all the giants in the field, in the heart transplant, in the innovation, and so everything is, I mean, coming together is perfect. So
wow.
I'm now so with, I have to say the culture of the institution, the culture is very important to do this kind of breakthrough procedure that has not been done because everybody tend to, like you remember the old days when you do lap chole or someone, everybody is scared, right? And then they're all criticizing why you do that. And the gold standard is the laparotomy. And now the heart transplant, I heard people say, why do you do the robotic? The gold standard is sternotomy. They don't see the value. But then in heart transplant, actually, particularly in heart transplant case, there's distinct benefits from sparing the sternum. Number one, most transplant patients will be on immunosuppressant, especially the steroid. And then for those patients, especially female patients with osteoporosis, and then the bone density can be a challenging, and avoid sternotomy certainly will, and avoid this healing issue. The risk of infection through sternotomy, that's all not concerned. Also, the sternotomy typically cause more bleeding and requires more transfusion of blood products, and avoiding blood transfusion and the blood products transfusion in the heart transplant patient minimum. That means decrease the risk of future rejection risk and the antibody forming. So I think in heart transplant particular, and the non-Sternum approach has a unique place here. So hopefully with us leading the way, the more centers started to follow, and then hopefully we can learn from each other, and started to see this coming, this procedure done more frequently and benefit more patients.
Well, absolutely. I'm absolutely sure this is going to take off like wildfire. This makes so much sense, just as you say, and it's absolutely fantastic. I really hope you videoed it. We're desperate to see the video. So either video
Sure.
this or the next one, because I'm sure the world wants to see this
Yeah,
incredible approach. Yeah.
yeah, we're adding the videos, and then so that we can organize, we're gonna hold it, yeah, send out for publication or viewed, and that your network, and it is good. As you said, the Baylor, and then to pursue this is not easy. I have that personally. I would be say. Before did this surgery, I talked to my boss, Dr. Rosengart. I said, I'm going to do a robotic heart transplant. He heard about it. He's supportive. He said he could be careful. But anyway, I think something like I think with he's a chairman, he's a cardiac surgeon. He was a chairman, so he understands. So that with his backing, with his support, that make my life easier. I know that I'm in a good position to do this kind of procedure surgery, and that's actually helps a lot with psychological and also the institutional support commitment. So that means a lot. Otherwise, it can be challenging without the understanding, without the institutional support.
Right. Yeah, well, certainly from us here at CTSNet and surgeons worldwide, really, congratulations once more. It's an absolutely immense effort, and we look forward to hearing, your first series of 10, then 20, then 30, then within 5 years it'll be the gold standard, won't it? So
I
from all
think
of us,
it's coming. You'll see more and more coming. Yeah. Okay.
well, so great to meet you, and a true pioneer, and once again, congratulations from all of us here at CTSNet.
Thank you so much, Dr. Dani. Appreciate your invitation and looking forward to share our work with the rest of the cardiothoracic surgical communities. Thank you.